it is.
You're extra, extra expressive.
Who, me?
Yes.
Gas.
Thanks today. Buddha, your presence is made after gases.
Gaseous.
Gaseous.
Speaking of gas, let's talk about diffusing capacity, because that's what we're going to use to measure evaluate the diffusion across the velar capillary membrane. Symbol we know is DLCO. It's predicted based upon your various parameters, and the normal value, as you saw, was 25 milliliters. There's a couple different ways to do it, although the single breath is probably the most common utilized. And we use carbon monoxide as the tracer gas because it's rapidly diffusible across the alveolar capillary membrane. And part of it is that the patient should be reminded that they can't smoke for at least 24 hours. Had one student one time that came in and brought in his mother's PFT, and the carbon monoxide was like through the roof, like 250% are predicted. And I said, she didn't have a cigarette on the way there, did she? Goes, oh, I'll bet you she did. She was nervous, she was scared, so she had a cigarette. Wrong thing to do. It's evaluated based upon lung volume, so it's always corrected for that. So if someone has reduced lung volumes, it's going to affect their diffusion, but you want to see what it is for their given lung volume. But it also measures the thickness of the membrane along with the surface area, and it also has some effect as far as the blood volume in the tracheobronchial or pulmonary system, and the distribution. So VQ mismatching by changing body position can make a difference in the diffusion capacity. And it's also corrected for the level of hemoglobin, since you have to have hemoglobin for the carbon monoxide to bind with. This is kind of what the system looks like. You have a helium and a carbon monoxide analyzers. Basically, they're drawing a small percentage of carbon monoxide in, holding their breath and exhaling back out again. And from that, they're able to assess what the carbon monoxide level is as they exhale, and therefore how much is being absorbed. This is kind of what the test looks like. They take a breath in, they hold it, hold it, hold it, hold it, hold it, and then they exhale, and they sample how much volume there was and what the percentage of carbon monoxide was. Beyond that, you really don't need to know that much about it. Second test that's kind of a unique one is bronchial provocation. And remember, this is where we want to identify hyperactive airways when somebody has symptoms of bronchospasm or symptoms of asthma, but they don't respond let me rephrase that. They don't show it up on a PFT test, so it's a normal PFT, or bronchodilators are not definitive as far as relief of this, what appears to be asthma. They'll bring them in for bronchial provocation. Usually it's methacholine that they use, although there's a bunch of other things that can be used as provocative agents to trigger a bronchospastic event. They use a specialized nebulizer called a dosimeter, which will deliver very precise concentrations of the medication. And we want to look for spirometry changes, and there's something called the PC20, and that shows when there's a 20% reduction in airflow. And that is the sign of there being significance. If you can demonstrate that there's a 20% fall in usually FEV1, then that's what we're going to use as our indicator to say that it's a positive test. Okay. And obviously, because you're inducing bronchospasm, you really need to monitor these patients closely. And here you can end up seeing that they go from 4 to 3 is a drop of 25%, and they can basically point out that as I increased this dosage of methacholine, I got to a point where I ended up having, it crossed over that 20% line, and I could go ahead then and verify that there was a reversal of the agent after I gave him a bronchodilator. So you want to do two things. You want to identify where that PC20 is, and in this case it's something a little bit more than 0.25 milligrams per milliliter. It's a positive test, and I verified that I got a return to normal pulmonary function by giving them a bronchodilator. Kind of a nice thing to do.
Hey, Rick.
Yeah.
I really have a gray area on when we would actually really want to do this on a patient. And
Somebody
how-
who has signs and symptoms of asthma,
Right,
but their
so
PFTs are normal,
let's say they had an asthma attack, they're in the hospital.
and we wouldn't do it then.
Okay.
Because that's known.
Then let's say that you think they might have asthma, maybe even like a COPD component, and you give them a bronchodilator because maybe they have like the chronic cough and they meet the criteria there, but then you think they might have some little expiratory wheeze, but under the COPD component, you could probably give them a bronchodilator.
Yeah.
Why would we want to like, it just seems mean.
Go ahead, Brian.
Want to,
My dad's wife, she works in an engineering firm and she works in a print room, and the dye that's used for those big blueprints made her cause her to have hyperactive airways over the course of 20 years.
And this is a way to document and verify.
They did this test on her because she doesn't have any asthma issues, but she was getting this problem breathing and she was becoming short of breath and hands were getting numbly, like tingly and stuff.
And if you were to do a PFT, it would probably come up normal.
so they don't have to have asthma. When
Correct.
you say hyper airways,
It's reactive. It's hyperreactive airways. It's not necessarily an allergic component asthma. In fact, it rarely is. It's usually one of the what we used to call intrinsic asthma. Term is no longer used, but it's that kind of a patient.
Thank you.
That's fine. There's also exercise testing where we would evaluate the metabolic response of the cardiopulmonary system, and we would monitor not only our normal respiratory parameters as mid-ventilation, tidal volume, frequency, but also using a gas analyzer be able to identify their oxygen consumption and CO2 production, derive a respiratory exchange ratio, which is similar to respiratory quotient. Technically, respiratory quotient is what goes on at the cellular level. RER is what we're measuring as an exhaled airway. And defining an anaerobic threshold, which is basically the point at which they become anaerobic. So during their exercise, we're pushing them so far that at some point they no longer are able to adequately deliver enough oxygen to the muscle, and they start utilizing the non-Krebs cycle or the anaerobic pathway to it. And we can use a treadmill, we can use a bike, we can use an arm ergometer. There's multiple ways to end up doing this. I think I covered this again next semester, but just wanted to talk about it now too. We use it to evaluate their exercise tolerance. So somebody who's coming into a pulmonary rehab program will often have this done prior to and after a period of time of being in the program to document its success. We can use it to watch for desaturation using oximetry, although there's probably just a 6-minute walk test is a far better way to end up doing it. And for those patients who have exercise-induced bronchospasm, exercise-induced asthma, this is a way to confirm it also, to put them under a controlled condition and watch them deteriorate with it. And this is that anaerobic threshold or ventilatory threshold I talked about. And you can see that as ventilation increases, or as you exercise longer and you start getting to the point where you're using more and more oxygen consumption, at some point the minute ventilation it's no longer a linear response, and you can see the slope of the line changing. That's the point at which I'm no longer using as much oxygen for the amount of work that I'm doing. And that's called the anaerobic threshold, where the demands for exercising muscles exceeds the body's ability to provide oxygen in the process. Muscle strength, I think Mary probably covered this last year when you're in your procedures class, talking about the maximal inspiratory pressure and the maximum expiratory pressure. The term NIF is probably not the best term because it's not a measurement of force, it's a measurement of pressure, plain and simple. So the maximal inspiratory pressure tells us the strength as well of the inspiratory muscles. MEP tells us the strength of the expiratory muscles along with the vital capacity. So we're going to go ahead and draw in a forced inspiration against an occluded airway. Ideally it should be measured at residual volume or at least FRC. It's not always done, especially in the ICU, in that fashion, but it's measured either in centimeters of water or millimeters of mercury. There is a small leak that is introduced if you're doing it for the patient who's spontaneously breathing without an endotracheal tube. And that small leak allows for the effects of the cheek muscles not to be involved. We use it to measure respiratory strength. We can do it prior to extubation. Ideally, you want to look for some reproducibility by getting 3 readings. And you should obviously record the maximal value that you end up seeing. Normal values, something greater than -60, so we all have pretty strong inspiratory muscles. We'll see these reduced when you have patients with neuromuscular disease. This is obviously one of the things we want to monitor if we have Guillain-Barré or myasthenia gravis. But it can also be there for other kind of deformities. Okay, and obviously below 20 is a sign that they need to be not necessarily mechanically ventilated always, but certainly their airway they need to protect it. They don't have enough cough pressure. Expiratory pressure is the same idea. We're usually measured at total lung capacity. And again, a small leak is present in the system. And it's a little bit higher the pressures you can generate simply because you're measuring it at TLC as opposed to RV. And again, same kind of situations that you may end up seeing the values be reduced in. And here's my little adapter, or my system I would utilize to be able to measure it. And then there's my little my little port that's there. And then as far as differential diagnosis, this goes back to Egan. Restrictive lung disease is more parenchymal. Obstructive diseases are more associated with airway problems. And we define it as a reduction of maximal airflow. And this is the American Thoracic Society's definition: defect, disproportionate reduction of maximal airflow from the lung with respect to the maximal volume, obviously the vital capacity. Always associated with an airflow limitation, predominantly on exhalation as opposed to inhalation. We can measure the airway resistance to evaluate it, and we know that we look at the FEV1 FVC ratios, the beginnings point, and that is typically less than 70%. The FEV1 then is reduced, usually. The FVC may or may not be reduced. Given enough time, they can get back to where they are predicted-wise, but the FEV1 is definitely the key part you want to look at. And these should be totally normal to your C-babes. Other things, we talked about goiter, we talked about vocal cord dysfunction. Technically, croup and epiglottitis are obstructive lung diseases. We don't really think of them that way, but they are. And other causes of increased resistance, again, it's not all smooth muscle constriction. It's the chronic inflammatory process and accumulation of mucus that causes problems also. We know about that dynamic compression. The FEC, the first 20 to 30% of it is effort dependent. After that, it's not. So those small airways usually are quite reproducible in somebody who has lung disease. The reason why that collapse occurs is secondary to that equal pressure point. Under normal conditions, when we have a forced exhalation, the positive pressure inside the lung, you don't reach that equal pressure point until you're pretty much all the lung volume has been emptied. When somebody has dynamic or dynamic compression, weakening of airways in the smaller airways, that point becomes far more peripheral, which means that you end up trapping more gas. This is the reason why on a if you're looking at a flow volume loop, patients with COPD, that middle 50% of the vital capacity is where you had the scooping out. That's those small to medium-sized airways that don't have strong cartilaginous support and collapse down. We no longer have the new gold standards, remove the at-risk category, and we now just have the mild, moderate, severe, and very severe, and can remember that you're dealing all of them with the ratio less than 70%, and the secondary criterion is basically looking at where your FEV1 is. Between a 50 and 80 in moderate, between 30 and 50 in severe, and less than 30 with chronic failure and very severe. Yeah, they're trying to, again, go to the lower limits of normal as opposed to using the 80, not so much with the FEV1, but more so with the FEV1, not so much with the ratio, but with the FEV1 itself, looking at the lower limits of normal. And I think we talked about that last time, where it was a 95% confidence interval, blah, meaning 5% of the people who are normal will get classified as having disease as a preventative measure of looking at the other people who have disease slipping through the cracks. So this is the new, you don't have a slide, do you? Yeah, so I won't ask any questions on it, but this is the new gold risk classification, looking at how they are on their symptom scale as far as their breathlessness, their risk of exacerbation, and their airflow limitations. So this is what we were classically looking at, is this category, 1, 2, 3, and 4, mild, moderate, severe, very severe. And what they're basically saying is that we're putting them into one of 4 quartiles based upon their symptoms and their risk and their class and their airflow limitation. And we'll just leave it at that. Gold is always updating new ways to classify folks. The restrictive end is just a classic reduction in lung volume, specifically total lung capacity. Usually they have a thoracic compliance or a pulmonary compliance problem. We know it's getting air in is the issue, and it's more parenchymal than it is airways itself, so you end up seeing it. Can be a group of lung diseases known as interstitial lung disease, and we didn't really touch too much on that when we talked pathology. I just kind of grouped them together. There's over like 120 different interstitial lung diseases, and some of them are quite difficult to differentiate unless you're doing a lung biopsy. But certainly any of the pneumoconioses, remember what those are? I didn't think I taught you anything. Dust disease, yes. Any of your various dusts, berylosis or psittacosis or whatever. No, psittacosis wouldn't be one of them, but at any rate. And then diseases of the chest wall, we don't really think about them that much, but certainly they can cause as much problems as a true interstitial lung disease. And they're, again, classified as a restrictive disease process. The other ones that they're classified as restrictive, although they're not really lung diseases, because the lungs typically are perfectly fine. As far as a functioning gas exchange organ, there is not a problem in the neuromuscular groupage, but they're restrictive because they can't get the air in. So they fall into that category. Guillain-Barré, myasthenia gravis, amyotrophic lateral sclerosis, and paralysis of one or both of the hemidiaphragms for some reason. And then pulmonary edema obviously be classified as a restrictive lung disease also. But in all the restrictive, you have reductions in lung volumes. In obstructive, you have an increase in trap gas, specifically RV, FRC, and TLC. So again, you should be able to, given a PFT, differentially diagnose which category they fall into. Okay? And I'm going to stop there.